So welcome to the January Journal Club. This is Jessica.
Liz, and Rainey.
Article is Efficiency of Active Release Technique in Tennis Elbow, a randomized control trial. What is tennis elbow? It is cumulative trauma disorder of the elbow. It's associated with overuse or repetitive stress. It affects 1 to 3% of the population, both athletes and non-athletes alike. It's characterized by pain on the lateral side of the elbow that is aggravated with movement of the wrist, by palpation of the lateral elbow, or by contraction of wrist extensors. Continuous trauma to tissues prolongs the inflammation process of healing, which can lead to excess scar formation and fibrosis of involved tissue. Fibrosis of tissue can lead to eventual adhesions, which in turn contribute to the characteristic symptoms of cumulative trauma disorders. What is active release technique? It is soft tissue manual therapy used for persons with cumulative trauma disorders of the upper extremity with the aim of addressing the underlying mechanisms causing discomfort, pain, and functional limitation. This technique requires extensive training over a period of 1 to 2 years to become proficient. Proficiency includes determining locations of soft tissue adhesions, understanding the anatomy of and relationships between soft tissue motions, as well as refining movement specific to each condition. Treatment is dependent on specific problem areas and is therefore unique to each individual. Active release technique works with the basic premise of providing tension to abnormal tissue in combination with specific movement including shortening, elongating, and gliding tissue relative to adjacent tissues. So here's a video we have for you.
Okay, so this study was a level 1 RTC, and the objective was to evaluate the effectiveness of active release technique on functional performance in patients with tennis elbow. This was assessed by the patient-rated tennis elbow evaluation and pain-free grip strength. There were 30 patients in this study that were recruited by the College of Physiotherapy in India, and patients were referred if they had a diagnosis of tennis elbow. Inclusion criteria included complaints of present pain for at least 1 to 3 months and a diagnosis of tennis elbow. Exclusion criteria included no limitation in range of motion, bilateral complaints, decrease in pain for the last 2 weeks, severe neck and shoulder problems, treatment for the current episode, and inability to fill out questionnaires. The measurements used in this study included the patient-rated tennis elbow evaluation, which is a self-report of pain and function, as well as the pain-free grip strength, which measures the amount of force generated to onset of pain. Both measurements were used on day 1 and day 14.
Intervention. 15 subjects in the intervention group were treated using active release technique 2 times per week with a maximum of 6 intervention sessions over a 3-week period. In addition, they received conventional therapy for a total of 14 sessions. All of the interventions were conducted by the same physical therapist, and as soon as complaints resolved, the intervention was stopped. 15 subjects of the control group were treated using a protocol that was used in a previous large-scale trial on lateral epicondylology, or tennis elbow. During the 3-week intervention period, the subjects underwent a total of 14 intervention sessions. Every session included pulse ultrasound treatment of the lateral humeral epicondyle, and this ultrasound was given at 20% duty cycle for 7.5 minutes and was given with an intensity of 2 watts per centimeter squared. When pain subsided, subjects were instructed in muscle strengthening and stretching exercises by the physical therapist and were told to perform these exercises at home twice daily. These exercises consist of movements against resistance, rotational exercises, and occupational exercises. All sessions ended with the stretching exercises of the wrist and elbow. Subjects were instructed to use the affected elbow to their pain threshold, and when pain had resolved, the intervention was stopped. The intervention and control group both showed statistically significant improvements between day 1 and day 14. There was a statistical difference in improvements in reducing pain and improving strength and functional performance of the upper extremity, as assessed by both the patient-rated tennis elbow evaluation and the pain-free grip strength, with greater improvements in both outcome measures in the intervention group as compared with the control group. In conclusion, this small-scale pilot study concluded that active release technique is effective in reducing pain and improving strength and functional performance of the upper extremity over the short term. Results of the study also supported that ART may be more effective than other interventions. Further evidence is needed in a larger scale randomized controlled clinical trials, bigger control groups, and longer follow-ups, using comparison between ART and the most commonly used interventions for tennis elbow, and evaluation over the short term, intermediate term, and long term. Further, some strengths and weaknesses were that this was a high level of evidence in that it was a randomized controlled trial. However, the study only employed 30 participants, making it a small sample size. This limits ability to generalize this study to a larger population. Although reported by researchers as valid and reliable, the patient-rated tennis elbow evaluation is a self-report questionnaire which indicated that significant improvements and differences between groups noted by the primary outcome measures are dependent on subjective reporting by the patients and may impede reliability of results in some way. No follow-up was incorporated in this study, and this does not allow researchers to determine if the short-term improvements seen in the study can be maintained over time. That concludes our presentation for today, and if you have any questions, you can feel free to send any of us an email.
Thank you.